that will help us to not only improve our managerial skills, but also give us insights on the healthcare system and specifically the health financing landscape in Kenya. So it's a very interesting topic. And with us is our speaker. We are very privileged to have Mr. Samson Odongo. Mr. Samson Odongo is a specialist in matters health financing. He's also a specialist in matters health system strengthening. And today, Mr. Odongo is going to be our speaker. Such a privilege and honor. Mr. Odongo holds a master's degree in health economics and policy management from the University of Nairobi. Mr. Odongo is also a PhD candidate at the Mary University of Science and Technology. And Mr. Odongo is also privileged to serve as the registrar Outspan Medical College. Mr. Odongo holds many years of progressive experience, and he's a hands-on consultant in Master's Health Economics. And I want to take this opportunity now to welcome Samson to proceed. Samson, if you can hear me, you can unmute and just proceed. So if you have any questions, you will wait until the end of the presentation, write them on the Q&A section so that we can be able to discuss at the end of this presentation. Thank you so much. And once again, on behalf of LMSK, welcome everyone. Thank you so much, Samson, if you can hear me.
Okay, thank you very much. I'm able to hear you clearly. And I'm also privileged to be onboarded on this particular platform and also to participate in strengthening healthcare. And to this particular specific platform is empowering lab practitioners. I'll be able to go directly, and thank you for that particular introductions. Thank you very much. Yes, indeed. I hold Masters in Health Economics, and I'm more interested in health strengthening. And it is for this particular purpose that I saw it wise to prepare this particular content. I'll go directly to the content of my presentation, and we'll be able to learn much in understanding healthcare system as a whole, and also just understanding when someone mentioned about health system, what does it entail? So the objective of this particular presentation is to improve healthcare managerial skills. Along as the days when only a Bachelor of Science in Medicine and Surgery or a doctor in medicine was given that privilege or had the privilege to be a medical superintendent. It is in this particular generation when a medical superintendent can be a medical professional from any cadre. You can be a medical superintendent as a lab technologist. And therefore, it is my privilege to share that we need to embrace and even to equip ourselves with managerial skills as we now prepare to contribute in universal healthcare coverage. So for that purpose, as we move towards understanding financing, you'll be able to understand it is one of the elements of the health system. And therefore, the content is best when we learn health system and how can we strengthen it. And now, how can we strengthen it from the financial point of view? Now, as an overview, health system incorporates both formal and informal healthcare. And let me just explain that a little bit. We have got herbalists. We have got traditional birth attendants. We also have got universal healthcare facilities. Now, when you are describing or when you are analyzing a health system of a given country, you have to mention the structure and the integration or collaboration for each. We have countries like India, which actually has embraced the universal and traditional healthcare as a one system, as an optional. You find an hospital, a universal hospital, which has got doors to herbal medication. And we cannot run away from that because even where we live, we still have our people who still believe on traditional healers. And we still have our Maasai men giving us some concoction. And therefore, we have to acknowledge that health system incorporate both universal or formal, to say, and informal sector. And therefore, what are the elements of health system? One of the key elements of health system is administration, and that is health management services. Within that particular sector, this is where the organization and planning take place. When we have health system financing, which is one of the main pillars, and interestingly, that this is one of the pillars which can also be used as an indicator of how strong a health system is. Okay? Then we have got human profession, or human resource, or human capital, which also provide the service. They are very, very important in input aspect when we are talking about the service delivery. Then we talk about the service itself. What service are we delivering? What service do we have in our country? So that we can see, do we have deficient health services? Do we have, are our services well packaged that they're adequate enough to meet the health needs of our society? Then we have the product and technology. This has changed for in the previous decade. It has referred to pharmaceutical and pharmaceutical products and non-pharmaceutical products. But now it has been repackaged to mean product and technology. And I believe this particular pillar opens more to a lab technologist. Okay? Then we have information, surveillance, and research. The activity that Lab Society of Kenya is currently undertaking directly touch on information, surveillance, and research. So we're able to see how these particular pillars look like. We have the pillars that we have mentioned. We'll touch on patients, we'll touch on payer, we'll touch on the provider, and we'll touch on the professional. They are interrelated. Now, for our health system in Kenya, we can describe it as a mixed model. It is a mixed model in the sense that it will incorporate the public model and the private model. So when we are talking about health system, we don't need to discriminate, or we don't need to only focus on public only. Therefore, we also need to focus on even the private sector, because it is the whole system that makes up our health system. Now, the elements in terms of interrelation, you can see the way they communicate with one another. We have financing pillar, which also mention on how we either mobilize fund, pool resources, and pay for the services. And it means, therefore, that we'll have a public system of pooling of resources, mobilizing resources, and paying for the services. We also have a private system which also organizes how to mobilize resources, pool the resources, and also pay for the services. Then we have got the input aspect. The input aspect, as I have mentioned before, it describes about the human capital, the product and technology, the infrastructure that we need to put in place. And you will also appreciate that at each pillar, they are associated with some legal framework. Then we have information, research, and development. at this particular pillar, we also need to look back and ask ourselves, how do we develop a lab technologies? Which curriculum do they use? How confident do we have that they can practice and give us a valid diagnostic results? Do we participate in research? What are the current and emerging issues? Then we have got oversight. And the oversight comes in two levels. We have got the professional oversight, we have got the government oversight, and the international oversight. And it is this particular level that we also ask ourselves, what standards of practice do we use? Are they local standard? Are they institutional standard? Are they international standard? And how best do they support service delivery? Because at the core of these pillars is the service delivery, which needs to be efficient and accurate. Then we have leadership and governance. This is a good example. The society has got some level of organogram, and it defines the responsibility and roles of each and every member. So how accountable are we to our duties at the lab section? And how do we collaborate with other departments? Because our goal is one, to provide cost-effective services. Then we have the outcome. In whatever we do, we must be objective-oriented. In the services that we are undertaking, we must be guided by objective, the mission or the vision of our institution. Today, as a public sector, we are glued towards Vision 2030 as we answerable to Sustainable Development Agenda. And then we have got specific outcome indicators in healthcare that we have to regularly, either in terms of routine data or non-routine data, monitor our status of healthcare. So this model cannot operate as a public alone, and it can also operate as a private alone. It is a mixed model that answers the question on how do we provide services to our patients? Who provide those services? Who pay for those particular services? Where do we get the finance to run this particular system? And this question is even direct to an independent health entrepreneur who would want to invest in a laboratory technology as part of the system. So therefore, when you are analyzing a health system, and because I'm presenting this, believing that we are not limited to practice in the lab alone, but we can have project managers. And we are challenging ourselves that medical superintendents in both private and public is not only limited to one cadre. And therefore, we need to equip ourselves with a strong monitoring skills. Now, when we are doing analysis for a health system, we peg our elements on the healthcare system elements. And we conduct this through stakeholder analysis approach. So this particular approach actually takes the form of stakeholder analysis. So when we start with the patients, we're able to ask ourselves, how accessible are health to our patients? And if it is accessible, are they able to afford? And if it is accessible, to what is the level of quality? And you know, for a lab technician, when you're talking about quality, you'd want to answer the questions of specificity and sensitivity of diagnostic processes that we conduct. And what are the powers of our patients Remember the patients, the one who have got they have got the description of selecting which facility to obtain service from. So if you don't provide quality service, then therefore it means that you will not be in the market. And then remember the patients, they are one of the powers, or the other power that they have, that they have got the purchasability power. If the services are above their purchasability, then they are not able to access the healthcare. So when we are analyzing, we ask ourselves whether the services were accessible to our healthcare, to our patients, or to the populations, whether the services were of quality, whether the services were affordable. But again, at the core, we also need to understand the providers. The providers comes in form of government providers, private providers, community-based providers, faith-based providers. Their key concern is whether the healthcare system provide an enabling environment to grow, expand. That is a big question. But their power is they can control volume, they can control quality, they can control integrity. So if our system compromises these particular indicators, then remember the providers can compromise volume in terms of even the number of healthcare workers they employ, in terms of the number of infrastructure they can bring on board, and that also translates to quality. And the worst of it, they can compromise integrity. So again, to bring a balance, we also need to understand that the healthcare system need to have policy makers. And the policy makers can either be a professional like you, who now participate in understanding the accreditation checklist of a lab. Can also be an interest group like politicians who will focus on the excitement of their interest of their voters to be seen. Or further analysis can also open behind the scene the sponsors of a health bill and what is their interest. So at any point of a health policy, there is an interest group, whether it comes from the professional side of view, whether it comes from the investor side of view, whether it comes from a political side of view. We need to understand who are the interest group. But the policymakers, they have got one power, that they will always make rules. So then we have got regulators. Now, regulators should be independent as much as possible because they bring accountability and ensure that the services that we offer are actually to the standard or meet quality standard. Then we have got financiers. When all is said and done, we have to ask ourselves, where are we going to raise the capital? Where are we going to raise the input for the infrastructure? How are you going to pay our healthcare workers? How do we meet the operational cost? And at the end of the day, are these services will attract consumers? And to what level will they attract consumers? And how we do it balance health as a right, and health as a service. That's a big question. To a business person, health is a service. To a policymaker, health is a right. And that also answers the question of suppliers. The partners, do they make profit? Are we able to access their product? And remember, if we do not take health system seriously, then the quality of our product will be compromised. So these systems are interrelated. So therefore, we ask ourselves a question: how do we respond to gaps in healthcare? The gaps can arise from any of those elements that we have discussed. But the answer is by carrying out health system strengthening. So what is health system strengthening? Health system strengthening, in reflecting back on the 6 building blocks, it entails managing interactions within those particular elements in ways that achieve more equitable, sustained improvement across health services and health outcomes. So you'll really have an imagination of the justice balance. I hope all of us understand the justice balance, where it's mostly used in the courts, where we have got one side and the other side of the justice balance being on the same horizontal, so that when one side inclined to the other, it means that we are biased towards one side. So that means that the inputs of healthcare, the elements of healthcare, should not be managed in a manner that the outcomes are not sufficient to meet the health need of our people. So it's that there should be a critical balance between the input side and the outcome side. And to further understand this particular segment of strengthening healthcare, you'll have a look onto the elements, the 6 elements, and what are the questions of concern in strengthening healthcare are the elements. And if I just make this particular diagram more practical, this is the diagram that enables us to develop objectives. When you are developing an objective as a department, when you are developing objective as an institution, because I believe that the quality standard require us to review our objectives on a yearly basis and also to monitor. So as we monitor our objectives, then we need to revisit each and every element as described in this particular cubic diagram. So the service delivery, we ask ourselves, what are we providing? That is the service package. What are the quality standards that we are using? Are people interested in our services? And that is more of customer care or customer satisfaction. In terms of healthcare professional, we ask ourselves, are there supervision that we provide? Are these healthcare professionals licensed? And we ask ourselves whether our lab technologies are licensed. And if they are not licensed, what are the implications? What are the risks? Are we adhering to our professional protocols? Not only professional protocol, but a service protocol for each and every diagnostic procedure required. Then we talk about information, and these also incorporate research and capital development, and that is personnel development. So we have to ask ourselves whether we are up to date with the current technology. Are we able to run the diagnostic request with the current technology, or that are answering the questions of today's healthcare? Then we have got the product and technologies. In this particular point, we address the drugs, the non-pharmaceutical supplies. We ask ourselves about the logistics used and even the rationale. The biggest question in our house is financing. It's again big questions can be discussed even throughout this particular week. And we'll be able to understand why financing is a very interesting topic. We ask ourselves, how do we raise, if you want to start an hospital, if you want to start a lab, where do you get even money? Because at the end of the day, you need money to start to run a startup. Do we have agents that can work with you during the startup? And once you have started your business, how will it grow? Do you have the clients? How will they pay? Are they able to afford such kind of services? Then we have leadership and governance. If I work in your lab facility today, will I able to have an organogram? Have you delegated duties to each and every person? Are the duties clearly stated? So these are some of the questions that this particular cubic diagram of a health system tries to clear. So strengthening medical laboratory service delivery, when you reflect on our cubical diagram, we will ask some of the questions as per the following levels of the elements. As a service delivery, you'll have a laboratory unit. As a way of understanding the performance or monitoring, you'll check whether your facility has approved service package. Do you have service charter? If I just walk into your unit, have you displayed the service charter? Is your facility accredited? Do you have internal quality system? Are your service in demand? Or what is the demand level of your services? Then on the side of healthcare workforce, we'll ask yourself whether the processes conducted within that particular lab unit are actually learned by licensed laboratory technician or laboratory technologists. Are you complying with the KMLTTB? Do you have a legal contract? Or you're misusing lab technologists? Okay, are we taking advantage of them? How are work distributed? Do we have the skills required? Okay, because now we are running away from the qualification. The CBC tells us that it's the skills. So do we have the right skills to operate and diagnose the requested lab test? In terms of health information, as I've mentioned, it enables us to carry out monitoring and evaluation of our system. And one of the key processes that we use is QMS, Quality Management System. So do you have one in place which outline the processes that we are actually undertaking? If it is about the phlebotomy process, if it is about releasing the result to our clients, if it's about communicating results to other users, how is your processes efficiently supporting the service delivery? And this particular system will enable you to make decisions in a timely manner and to have reliable reports. And this one will also going to ask if it comes to life, the bill for quality of healthcare and patient safety. It's a very interesting bill. And this particular segment of healthcare sits at the core of that particular bill. We have medical products and technology. In terms of this particular presentation, we're asking ourselves whether we have laboratory equipment and the reagents, what is the pricing, and that is the performance, what is the distribution system, what is the protocols that are being used to handle reagents or to handle a given particular diagnostic test. In terms of financing, we think about funds and where do we get the capital? What fee policy do we use? What are the insurances available to clients or to our patients? Given that health is an unforeseen incident, and one of the objective of insurance is to prevent, social economic improvisation. So lastly, we think about governorship and leadership. I think I've mentioned this. It mainly explains the management of a laboratory units. And you have to come up with the clear roles or clear roles which are consistent with the qualification, coordination of the processes, accountability mechanism, and partnership. If you are partnering with an institution, do you have a legal partnership contract? If you are obtaining an external service, how is contract formulated? Okay, so governorship is very, very critical in terms of managing your lab system. So how can we focus on our measurable objective? And this particular one is very core to those lab technologists who are working in NGO. You have got a target, or you are a project manager. Now, to make your work easier, learn your core services. And then supporting services try to delegate, try to contract, so that you can remain with core services. It's not important, it's not possible for you to run all segments of service delivery. And that is the reason why I'm saying you can actually contract high operational core services and non-clinical services. There are some tests which require high level of expertise, and probably it's not feasible or financially feasible to employ a specialty in such kind of service, which are rare, and therefore the best you can do is contracting or part-timing or having an expert on call. Services like cleaning services will probably require contracting. Okay, so try to understand the objective of the unit and then analyze the services that you can actually contract externally. By doing so, you shall have services that are critical to your objectives and ones that you are capable of delivering. So this is one of the game changer which many facilities are using. Even in banking system, when you walk into a bank, you will find there are some services which have been outsourced. If you walk into hospitals, there are some services which has been outsourced. If you walk into even our private facilities, even public facilities, you will realize that there are some services which has been outsourced so that we can remain with either preventative and curative services. So as we have a look on health financing landscape in Kenya, we are now able to appreciate that finance is critical and it supports various elements from administrative to human capital to infrastructure to product and technologies to research and even to service delivery, which is very cool. Some administrative services will even cost as much as 60% of your budget. As much as a healthy budget system should try to minimize administrative services below 50% of the total budget. But it's something that we're able to realize that administrative services takes much, but it is very important because it actually provides accountability, monitoring, and efficiency of the service delivery itself. So health financing answers the question of where do we get the resources? How do we pool them together? And how do we buy health services? So when you walk into any health system in any country, remember, one of the core is to improve accessibility of healthcare and also to minimize making a population poor due to health costs. So it's a system that will try as much as possible to prevent making a country more poor or population more poor due to health costs. There's a very strict balance. The main models, there are several models, but some of the two main models that are existent, we have a disease stroke case specific. And this has been operational, and actually most of the NGOs perfectly work with that. Disease stroke case specific financing model. Then we have got the common model, which is, I can say it's a primary model, the system-wide financial model. Now the system-wide financial model, it is, first of all, it's long-term, and it answers most of the critical questions. So just with a nutshell, when you have a lab technologist who needs development on a given skill, you will take them to a training on that particular skill. That one is case-specific model. But if the entire lab society are raising a pertinent question on skills which cut across everyone, you will go to a system model by looking into the curriculum, the education system. So by raising changes on the education system, that one is a wide, system-wide financing model. You will say, no, instead of capacity building one technical lab technologist, and yet this is a case which affects everyone, then let's revisit a curriculum. Let's revisit a policy. That one is system-wide financing model. But if it is in terms of a diagnostic case, if it is arising, if it's a case that is unique to a given disease, you will come up with a model which raises probably a machine for that particular disease only. That one is case or disease-specific model. So therefore, once you understand that there are other financing models, but the main ones of use is either case-specific or system-wide financing model, the one which is of commonly used is system-wide, and therefore it is one that we are going to discuss here. It is one that is with these the basic skills of a financing system, whether in private or public. Whether you're going to start your own lab or you're running an institutional lab, whether you're going to be a medical superintendent or whether you are going to be a manager of a given health, this is the financing system that or structure that you should be able to understand. So we have a healthcare system, let's say an hospital or hospitals. Later discuss about the startup or how to finance capital. But let's look onto how funds move from the patients or a public until someone receives the money as an exchange of service. So financing system discusses the source of revenue because it talks about collection of revenue. And what is this revenue? You have a person sitting in Nyeri, in a community in Nyeri, a teacher, for example. This teacher is healthy, but health is uncertain. We'll be able to advise that particular teacher to have some insurance for unforeseen incident, which is now health. So that teacher becomes an individual or a household. So he has money in his pocket. He can decide where to get sick, to go to the facility without using insurance pathway. That becomes out of pocket. So he will just wait to get sick, go to a facility here, be diagnosed, run tests, and pay out of pocket. Or that particular teacher can choose to register in an insurance model, or either to check the public model, public insurance or private insurance. And something that you are going to appreciate with public insurance, it focuses on the entire population. It asks a question: what is the common or the average health demand, and what is the cost of average health demand? So this average health demand might not really fit the need of this teacher X. So teacher X will be advised that the average the cost of average health demand will be up to this level. Past this level, the public insurance might not cater. So the teacher who will want to survive, because health is investment. Now I'm talking as a financial analyst. Health is purely investment. Whether you are taking exercise, whether you are paying insurance, whether you are visiting a physiotherapist, whether you are visiting comedy, all those are investment. So the teacher will say, in addition to public insurance, I also want to invest more. So the teacher is investing more in his health, okay, by adding a private insurance. So you'll see the funds from the teacher running from daily remittance, or I mean monthly remittance, either in form of a tax, you can see taxes, or as a contribution. So the Ministry of, or the Treasury in our context, the Ministry of Finance will collect the revenue on our behalf. So from your payslip, revenue tax will be deducted. An insurance policy will be deducted. And this insurance can either be mandatory or voluntary. I'll explain the difference. Okay, it can be mandatory for a given group or mandatory for all. Okay, I can see an hand is raised. I believe I'm clear. Would you want to have some? Am I audible? Okay, I believe I'm audible.
Yes, you are audible.
Okay, thank you very much. Okay, so I'll just continue. So Treasury will collect the fund and move it to a pooler. Now, a pooler depends on a government structure, whether it's a private, even if you move it into Jubilee Insurance, it will have a revenue collection and a pooler. Poolers will come up with the packages. So in our case, our pooler is Social Health Authority. So Social Health Authority is our pooler. It pools the funds from the ministry and now consolidate it in a fund to provide insurance. So again, remember I mentioned that as we move to the public or the universal health coverage is one of the most expensive, and it targets that a country is able to provide the average health demand without further payment on this particular average. It's very expensive. So we are going to appreciate that this particular types of public insurance, for example, the one we have, need to acknowledge our financial level of each and every household. That is per capita income, the GDP level, the cost of health in our country or health demand. Okay, so they have to take in consideration of all those. And to a person who will default payment, and those are some of the risks, associated risk. So once this particular fund has been consolidated, then we have to ask ourselves, then how are we going to buy the services? Now that comes a policy. So when you are joining a health insurance policy or a health insurance firm, they will give you a contract, health insurance contract form, or you will come into an agreement. They agree with you on how are you going to provide these services. Now that is costing of the health. And let's talk about the packages or the tariffs, so the purchasing. So the pooler will come, either they can do this through the brokers or the managers, or they will directly generate contracts. Based on the tariffs that they have, they approach the providers. They sit on the table. And one of the financing systems, maybe just to mention, a good financing system should be one which is participatory. Because the providers will also share. You have seen healthcare, the elements of healthcare system. This provider has got suppliers. This provider has got healthcare professional. This provider has infrastructure. This provider got into the business through a funding model. And we have to acknowledge that a health system is both public and private. And therefore, a good healthcare system or a good financing system, it is one which is participatory. So this is the general overview of how a health financing system works. Now, in addition to participatory, it is one also which should reduce as much as possible out-of-pocket payment. Out-of-pocket payment. So when you review the history of health financing from our independent or even pre-independent to date, or in any financing conference, you will appreciate that the discussion is all about the percentage of out of pocket or out of pocket as a percentage of total health revenue. How much of the total income in healthcare, how much was collected from payer, direct payment? So the one which is higher, there is a time when we actually out of pocket payment was over 50% of the total health revenue. So that one is really I can say it's one of the worst. It promotes poverty. It is degenerative, out of pocket. So any financing analysis should focus on how out of pocket payments is reduced. So collection of revenues, just as a way of reflection of that particular table, we have understand that revenues can be collected either through or from taxing or from public health insurance. And this is either voluntary. I think during the NHIF, there is only a specific group which were on compulsory contribution, mostly those who are in formal employment. But the rest, like in informal employments, were left to either choose to contribute or not, and that is voluntary. And it comes with associated risk, okay? And then we have now social health insurance. This is a global discussion. By the time NHIF was being implemented, actually, before NHIF, a social health insurance was proposed in Parliament. And it was dropped because it was so expensive. The analysis then was that our economy would not really support social health insurance. So in addition to that, we can do out-of-pocket payment, which is in addition, is a current practice to date as well. And it is the element that we are trying, or form of revenue collection that we are trying to reduce as much as possible. We have waivers and exemptions, which is actually conducted by the social authority, understanding who should be waived and who should be exempted. Sometimes back when we get a patient who was overstayed in the ward, and we send them to social department, and then an interview will be done, a request will be done to the ministry so that they can be waived. We also have got group who are exempted, like now the Linda Mama was an exemption. It's an example of an exemption. It is one of the best because waiver had a lot of bottleneck. So waiver is not the best way. You better do with the exemption and define a clear contract of revenue collection from the group are exempted. Now we also have private health insurance, which supplements the public one. In addition to private, we have community health financing. This can be done by employers and it's actually it has been taken well by most of the private insurance. You'll find a private employer consolidate its fund and then come up with some financing model or health financing insurance for its employee. It can also be done by a non-symptom. Like we have AA insurance. It is actually based on, it's a community-based health financing. If you find its history, it's more of a community-based. And most hospitals also have got this financing model where they have some premium for its members, and you can subscribe and pay monthly premium, and you can access some services. So those are community-based health financing. It can either be employer-based or an institutional-based. Then we have revolving funds. This type of financing was used mainly by I can say non-governmental organizations or donors. They will donate for you a startup capital, whether it is a diagnostic machine or a reagent, and then they ask you to charge a given cost or price to your services to enable you replace or refurnish your reagents, so that the clients will get the services at a cheaper cost. So it's one of the model which has been used by donors mostly. Then we have got external sources. So we have got donor funding, which can come in form of a loan or a grant. And in terms of grant or in terms of loan, you can be given a loan as a country, which is a common practice. And then you are given a condition, or either to benefit on this particular other financing institution, or to train your professional from this particular institution, or in form of a reduced scholarship or a discounted scholarship, or it comes with some condition, or buy a product and then maintenance to be maintained by this particular organization. So those are also forms of funding. So I've mentioned how will we classify Kenya. If you look onto this, maybe you can ask then, or after the end of the presentation, which type of financing or what are the sources of our finance as a country from this presentation. I believe after the presentation, you will be able to say, okay, I think Kenya is from this and this and this. So try to brainstorm. How will you classify revenue collection or sources of revenue as a country? So after you have collected the revenue, then you have to purchase. So purchasing is done by poolers, which I have to insist on that. Once revenue has been collected, revenue will be consolidated by a pool, and this particular pool now come up with tariffs. Sometimes an individual might not be in an insurance; they will just directly pay out of pocket. So, and out of pocket, we have seen its disadvantage. It makes a person more poor. Okay, so that one is clear. So when we look onto policy reforms, therefore, from in Kenya, how has it been from independent period to today's world or to current policy? What are some of the challenges they experience? So before then, that is around independent time, we had tax financing. Now you understand tax finance from the tax, okay? And then it targeted everyone. The impact that it has got limited utilization because the fees were unaffordable. So in this particular tax financing with a standard fee, it means that the government will pay the tax, and then it will be like the government will channel the fund to the facilities, but additional fee, or each and every facility will come up with its fee. And then those will be the service fee, which was standardized. The problem came, people were not able to afford even the fees. So it affected the accessibility. So they reviewed exclusive funding from the general government revenue, user fee removed. You can remember now that one, social health insurance is sneaking, or social health or universal health coverage is sneaking in a different way. So it targeted all Kenyans at public facilities, of course. Inadequate health facilities, that is a problem came in, that services were not of quality, facilities were not able to actually meet, to budget the internal services. So services became poor, and actually demand on private healthcare became more. So that called for renewal. And we can see now NHIF came in establishment. So this was compulsory for formal sector and voluntary for informal sector. So it has got some advantage. So we are able to appreciate the importance of insurance. But later, in 1889 to 1990, user fee were introduced again in all public facilities, and it also experienced similar challenges before. So, but the introduction of this user fee, which were done in phases, and it all targeted all public institutions, accessibility became again a thorn in the flesh of members of the public. In 2003, thereabout, they reduced user fee to a bare minimum. Either you were told to buy a card, and this was the cost. So there was some discounting. Yeah, that improved utilization in two ways. At least the facilities were able to collect funds or collect revenue, although small. But again, there were some services available now in public facilities. Now, in 2003, there was a bill, of course, which were proposed, National Social Health Insurance Fund. It was just proposed. But again, as I've mentioned, the then member of parliament or a task force revealed that it was not affordable with the then current economy. So in 2010, Constitution came into life. That is the 2010 Constitution of Kenya. It came to life, and it proposed that health is a right. That particular article was a game changer. Article 43 say that everyone has a right to health, and now that it's in it also, was aligned by Vision 2030, accessibility, improving accessibility to healthcare, and also the Sustainable Development Agenda. So this is actually the backbone of discussion of social health coverage. So from henceforth, or let's say as much as we live with Constitution, 2010 Constitution, a discussion of how health can be accessed to by all will remain a topic as much as we live. So in 2013, government introduced free primary care in all dispensary, which eliminated user fee at these facilities, and that targeted all. Free maternity care in all public sector was introduced. Devolution of health services was done. Health insurance for the elderly and disabled was introduced, and so forth. And then the reason why you can see NHIF was also expanded to cater for those particular special groups. So in 2010, in the agenda 4 of the Jubilee government, universal health coverage became one, and a pilot was done. I think there are some counties like Nyeri, Kisumu, Isiolo, and Makueni were the pilot counties. Although the report was not publicly launched, but there are several researches which have been conducted. And it was revealed that one of the challenges was, during this particular piloting model, the clients or the patients who were attending the services at the public facilities in these particular counties were not paying. So the counties were raising revenue, and they were being given a top-up by the national government. The same challenge which was experienced by removal of user fee, and that is in terms of having drugs or having ability to purchase drugs and services, were compromised. So the UHC model, which was piloted in these 4 counties, we could not even proceed with them today. So they had got severe financial implication. So in 2023, Parliament passed Social Health Insurance Act, and this is the giant in the room that we are now currently having, with all its disadvantage and advantage. But we have to walk the walk, because the Constitution of Kenya dictates that health is a right, and we have to achieve universal health coverage. So in a nutshell, I'll try to be brief. I'll try to be brief as much as possible. So this universal healthcare coverage that we have right now, the model that we have now, it is in 3 levels. So, or I can say it has got some pockets. Let me call them as a pocket. So they generate from various acts. So the first one is the Primary Healthcare Act. It covers level 1 up to 3. And it has got tariffs, which explain. So how does this work? It views a community as a unit of 1,000 households. So these 1,000 households in the community forms level 1. So from this level 1, they can be connected to a level 2 and a level 3. Around, that is dispensaries, community health centers, and so forth. So these levels become a spoke. So you can have around 3 or 4 spokes. And then these spokes are connected to a level 4, which is a hub. Now, if you look into a triangular triad, you'll be able to see the spokes and a level 4 as a hub, so that it can provide the referral system, communication. So that model will ensure that services obtained at level 1, 2, and 3 will be free. And this particular services at level 1, 2, and 3 is sponsored by or is paid by a tax. Yes, tax. As long as you're living in Kenya, and that is the aim, and you are paying tax, either from import duty, value-added tax, coal levies, at least, or income tax, you should be able to benefit. As long as you are a Kenyan with an ID, you only need to register. Then there comes a Digital Health Act. Why do I jump from primary to the other one? Is because of communication. You can see we have got a level 4 hospital there, we have got hubs, so there is need of communication. And that is patients' details. And remember, we also have got we have a Data Protection Act of 2019. And this particular act establishes how information should be protected. And to conform with that act, we have to have some legal framework on how to handle health data. So that comes into existence of Digital Health Act. So it just basically explains communications between different levels of healthcare systems, and that is communicating the patient's data. So from primary, which is sponsored by or financed by tax, or we have got social health insurance. This is financed by premium that we pay. And determination of premium is by mean testing formula, which covers some data to generate what amount you can pay. And remember, when I started introduction or when I started mentioning about insurance, I say that if it has to be universal, then it only targets the average health demand and what cost can it have in terms of purchasing. So that is what is used to calculate the premium. So when you go to seek services in the healthcare sector, remember, you should be treated the same way as a jobless person, as a person on lower social stratification. That is the mentality or the vision of social health insurance. And you also have to appreciate that life is all about survival. Yes, it's all about survival. And that's the reason why we do our best as healthcare workers. And therefore, even a health insurance model will do it best. Above that, it is for the survival for the fittest. How I wish it could cover everything. But remember, it has three principles. One is coverage. One is coverage. The second one is reducing social causes of social poverty due to health cost. The third one is accessibility or service package. So we have a coverage, how many populations can be brought on board, how best can we reduce incidence of poverty due to health expenditures, and then the third one, what can we provide? That is the package. So whenever you are discussing an insurance, remember it answers those three main questions. So this, in our current landscape, it covers services from level 4 to level 6. So a mind of a laboratory technician who is planning to have some startup, you'll ask yourself, where will you get the services then? I mean, where will you get the finance then? You can start with your own saving. You can start a laboratory using your own income. Okay, you can do a conditional placement. This is where you come into contract agreement with the manufacturer of a given diagnostic machine, and then you agree on either where you are going to source the reagents. So it's a conditional grant. How much? Sometimes the cost of the machine is hidden in the agreed pricing of the reagents or the inputs. You can also work on credit facilities like bank loans. You can go for higher purchase. But so there are several factors which determine which financing model or which fund model will you go for. So I've tried to brainstorm on some of the factors that you will consider. Of course, profitability is not mentioned there, but it's one of the main. Are you going to make profit? Because when you're not making profit, then you will not be in business. So that is number one, profit. So you have to do projection, financial projection, given any of the funds, financing model. How are you going to make, or how are you going to sustain your visibility in the business? The second factor that you have to consider is reliability and validity of the machines that you are going to purchase. Despite of any formula, when you are buying a machine, ask yourself, how true can it give you a positive result? Or how well can it detect a microorganism? Or how well can it detect abnormality? And how well can it tell you that abnormality is not existent? So how well can it define, identify absence of abnormality? Okay. Then technology. In the current society, we are discussing about the efficiency of communication. How will you communicate results to your partners? Okay, how easy is management or handling or operating the machine? How can it be integrated with the existing technology like phones and so forth? Probably you are providing a care, you are providing a telemedicine care. Okay, how can your patients or your client receive results? How can you integrate it with the current technology? We have maintenance cost. You realize that most of the diagnostic machines have got high maintenance cost. So if you are going to buy as a loan owner, are you going to manage maintenance cost? Sometimes when you look into the maintenance cost, that's the reason why placement arrangements become more superior than owning a diagnostic machine as a standalone owner. Then availability of the spare parts also becomes a thorn in the journey of owning a machine. Above all, you have to consider whether it is bank, whether it is a placement arrangement, whether it is a hire purchase. You have to consider the warranty period given and the contract terms. Read details. You can even take your form to your lawyer. It's allowed. If you don't understand financial implications of a contract, kindly just visit a financial consultant and a lawyer so that you can be clear. So what are some of the revenue collections opportunities that you can explore as a lab technologist too? You can make use of your network. Have professional networks that will earn you referrals, either clinics, either doctors or doctors' facilities or clinical facilities. Past professional network or human networks, one of the main key pillars in health creation. The rewards institutional partnership. You can partner with institutions which are covered by other insurances. Just be visible in the market. You can also earn revenue from participating in research. Several research uses diagnostic tools as a data collection or data analysis. So be part of a research colloquium. Just identify a colloquium, reach out, be visible so that researchers can reach to you. Okay. Then we have mobile services like mobile phlebotomy. You can specialize in collection of samples, probably from the community to a diagnostic center. And these are some of the opportunities that can be explored by lab technologists. So summary of our presentation as we come into hand is that healthcare system comprises both public, private, and informal sector. For effective healthcare delivery, interdependent approach is required for each element so that the 6 elements need to have collaborations and a balanced collaborations. A balanced check is required for health financing and service delivery and areas addressed by quality healthcare and patient safety bill. I think as the bill comes into life, probably we'll see how can we support it, how can it be improved, whether it is not good as it is as today. So we need, and we have seen the role of professional regulatory body, safety. So we have to stand strong. We have also seen the role of policymakers when we are analyzing health financing or health bill. So we have to understand what is the interest of the policymakers so that we don't become a victim. Yeah. So remember, each and every stakeholder has an interest. So we have to understand what is their power, what is their interest. So healthcare finance reform is continuous with the main aim of expanding services, packages, population coverage with the increased level of social and financial protection. So as we venture, as we criticize, as we learn health financing, remember, we are making strides to increase coverage, accessibility of quality healthcare. So both private and public health insurance require an oversight. Yes. So we have to also keep an eye on either of the financing system, whether it is a private financing system or a public financing system. So in addition to health financing, we also have a quality management system, awareness. We also do health program cost analysis, national health budgeting process. For those who are working in the county, you'll want to know when is the budget starts, what is your role, so that you don't complain that your county has received the peanut. You have to understand when does this particular budget goes to the parliament, as a proposal, as a bill, and when finally does it come as a law. Research methodologies and areas that I'm also interested in. I can empower the group. Ethics in healthcare, I'm trained by KEMRI to empower healthcare professionals and also to practice health ethics in areas of research. Thank you very much. I know it's a wide area. I wish I have enough time, more time, but the time I was allocated was enough to cover the areas that I was prepared of. I welcome questions, discussions on the same. Thank you very much, Fred and Lab Medicine Society of Kenya. Thank you very much.
Thank you, Mr. Samson, for such a wonderful presentation. We want to go to the Q&A section so that we can put the questions that our participants raised. We will start with the question, and it's kind of a statement, but then I'll read it out.
Yes.
It's from Ngeno Peter, and it goes, in a health system like Kenya's, where resources are limited and donor dependency is high, how would you design a sustainable financing of medical laboratories that ensure affordability for patients, fair reimbursement for services, and continuous investment in quality improvement?
Okay, thank you. Okay, as I respond to the question raised by Kipngeno, if I'm correct. Kipngeno, if I'm correct. Okay, thank you. So we have to appreciate the challenges that currently are experienced by diagnostic department or diagnostic services as compared to clinical services. Diagnostic services have received less empanelment to most of the health insurance providers. A few, I think, have received in the independent contraction or have been contracted by health insurance providers. And to answer that question is that remember when talking about the participatory health financing model, we have to incorporate healthcare providers and expand the service providers. We need to expand service providers and come up with a policy framework on how diagnostic services can also be accessed at a standalone level. I am aware that currently most of the insurance model cover corporate models, and that is institutional models, and less private laboratories are covered. But I would say that hospital, I can also improve on treating hospitals as patients and giving them tariffs, or hospitals or clinics as a patients, and giving them tariffs on types of diagnostic services they can seek from laboratory providers or laboratory diagnostic services. So if in answering the question, I can include healthcare facilities as patients. I can treat them as patients, and through that I can panel laboratory services, because by doing so, I will only need to approve or prioritize an hospital which lack one or two services and is able to seek such kind of services from an independent lab. I think that will improve, will empower laboratories and also remove brokers or brokerage of the current system. So I think I've answered that. Yes, another question?
So, thank you. My network had issues, but I think I'm back.
Okay.
There's another question from Francis Mwambire, and it's a question and a statement as well. And he says, nice presentation. How will you advise medical lab professionals who wants to invest in private practice, and highlight on the available funding models they can use considering the Kenyan economy? It's kind of related to the first question, but you can say something about it.
Okay. So, yes, I have to appreciate. Let's treat investment as a business venture, whether it is a health investment or a service. Of course, the traditional service investment. What you need to consider is the current, if you have to use other financing model apart from personal savings, the rest or any other financing model, which probably I'll give my opinion on, is that you have to understand the credit terms and you have to project on market return. Market return here means you have to project on the service demand in an area that you want to invest. And vis-a-vis the premium, the monthly interest rates that you are going to pay. That is very, very critical. There are some facilities, there are some, okay, this is an area that we need to do a lot of advocacy. Their health investment has received less of partnership. I'm not promoting financial institutions, but we need to explore banking, which has come with a package of health investment package. There are some which provide clinic franchisation of clinic. It means they develop a clinic in the bank, and you as an investor, they sell you a franchised clinic. That has worked for some of the banks. and it's one of the startup that one of the prominent bankers really used. Clinic franchisation, although they have got their own target clients, but we have others which are working with think tanks like Francis, and now come up with a package which fits them. But remember, it is a clinic franchise. So it means that you will not own the clinic 100%. There's some data that you have to constantly share with the bank as you get your commission to the point at which now you will own the facility. So there are some financing model for startup, as I've said. What you need to keep an eye on is the interest, your market return or return on investment. You need to really analyze that. And also you need to do a market survey on the available funding models, which can really facilitate your growth. If you have to go for banking, probably I will recommend you consider things like SACCO, or rather consider microfinancing models which has got low interest rates. So I think I've answered that question very well.
Thank you. Thank you for the two questions that you've answered. Another question from Wilfred Otieno, and it goes, and finally, due to delays in county reporting and accountability affects procurement cycles, do counties have sufficient capacity and timely disbursement to procure reagents and infrastructure? Maybe you can weigh in to that question, our presenter. Kindly.
Okay, thank you. County being a public entity, they have to comply with the public procurement legal framework and the financial system, integrated financial system, the famous IFMIS. These are some of the bottlenecks which also need I can say efficiency. We need to have integrated system which manages both finance and procurement system. It is not as simple as such. So it starts with the planning and financial models that different counties are using. Remember, some counties have got partnerships with the financial institutions like banks. So each and every county has got different financial models as a backup to address the delays. So it depends on the terms. But again, this is a national infrastructure. And like the reason why that some of the policymakers are pushing withdrawal of reagents and drug procurement from counties. So it's a discussion that we as professionals, we should join. How can a county procure within the legal framework? Because a legal framework will have to go through oversight process. And because as we have seen the elements of healthcare system, we have regulators. Kenya Bureau of Standards would want to ensure that each and every county procure drugs of standards, procure reagents of standards. So with the implications of oversight roles, procurement, legal framework, and the financial system, all this might contribute to a delay, but that should not give an excuse for a delayed provision of services. As I've mentioned, we just need to have a proper logistic. Communication and technology should be employed to promote efficient delivery of the reagents. So it's a continuous system analysis. If a delay occurs, what led to a delay? Was it approval? Was it the logistic part? Was it the personnel? And that can also be answered by quality management system. So, Mr. Otieno, as we discuss the the main problem of delay of provision of reagents. We also have to relook onto quality management system that we are using in our county. Do we regularly review them? Because if I mention here that we need to review our procurement system and our financial management system, that is not enough. We have to do continuous monitoring and improve our QMS. That is one of the main weapon we can use to address the delay. Thank you very much, Mr. Otieno.
Yeah, thank you, Mr. Samson. We want to look at another question from Diana Otieno, and it goes, hello, can you kindly explain to me a standalone laboratory and how it works? I don't know if you're able to answer this. It's more, but you can give it a try. Thank you.
Okay, thank you very much. I believe you are also able to help me explain. I'll just use my layman's understanding of a standalone laboratory. It's a laboratory which is just managed by an individual. Or most of the laboratories which are not connected to another entity like an hospital. So that is what, for me, that's to my level of understanding, I would relate standalone laboratory as so. Another person probably can also make clarification of the same.
Thank you. That is very much in order. We're looking at another question from Kezia Mungara, and it goes, insist that they cannot approve a lab separate from a facility, and insist that the lab must be within a facility and not a lab alone, not lab only. Some labs offer special services and they can stand alone. What is the implication of this, and how can Mr. Samson?
Okay, thank you, Madam Diana, for that question. I'll answer it in perspective of health financing. We have what is known as adverse selection and moral hazards, yeah? So a moral hazard is a patient just decide on their own that they want to be tested for, let's say, malaria. That one is, if they are not feeling, if they're just feeling weak, for example, they say, let me go test for malaria. You will not chase them away. That you know, you don't have malaria. Your signs and symptoms does not depict or does not impress or does not provide impression of malaria. So moral hazard is one of the concerns in paneling standalone laboratory as a beneficiary of a health insurance. And that's the reason why you as a standalone laboratory, you have to exist in a diagnostic process which involves assessment and a diagnostic process and treatment. So that the query for diagnosis to come from within a process. And many institutions have tried to manage this by collaborating with some labs. So you will charge the institution. And therefore the lab will not raise a bill to an insurance. So direct to the concern of Diana, it is a concern of moral hazard within the insurance. Thank you.
Thank you, Mr. Samson. Our last question is from Sebelina Kawira, but I think this question is more of more technical, that we will only advise Sebelina to visit the board so that he's able to get the quotation on how to register a Class E laboratory and the financial implication and the kind of equipment that are needed for that particular lab. Kawira, kindly visit the board or the website, and you'll be able to get every information on how you can upper class E laboratory. We thank you so much, our participants who today have come and join us in this particular webinar with our presenter, Mr. Samson. Before we close this webinar today, Mr. Samson, we will request you to give us your parting shot because our time is up. We are at past 4, and normally on at 4:30. So we welcome you again to give us.
Okay, thank you very much. I'll just encourage, as a professionals, we are part of the system that ensures we deliver quality of healthcare, and we have to take a role in leadership. We have to take the front leadership of the management of healthcare system in our country. As I've mentioned before, in addition to health financing, we encourage you to learn more of quality management system, which I've really discussed here. And for those who are working in public, we encourage you to learn more of budgeting processes. And above all, let us also improve on research. We need, how I wish we have a Journal of Lab Medicine Society of Kenya, where people who are conducting research in areas of lab can have a one-stop of accessibility of researchers on the current issues in laboratory sciences in Kenya. Thank you very much. Thank you, Laboratory Medicine Society of Kenya.
Yeah, thank you so much, Mr. Samson. To our participants, we thank you so much for making sure and creating time to attend today's webinar. We also remind you to visit our Learning Hub so that you are able to follow up on the topics that we've put there. You are able to learn much. We're also going to ensure that this particular presentation is active and live in our Learning Hub. So you can join our Learning Hub. You can always visit our Learning Hub and do more of learning. We also encourage you to join our WhatsApp group. We also encourage you to visit our YouTube channel so that you are able to also learn much of these presentations that we have in those particular platforms. Otherwise, it was a very wonderful presentation. And we believe that coming Wednesday, we'll have another presentation that will be wonderful as the one we've had today. Otherwise, I thank you all and I meet you again. I hope to meet you again on Wednesday. Otherwise, my name is Arthur Imari, the Lab Medicine Society of Kenya, Secretary General, and I wish you a good evening. Thank you.